The Critical Care PRN is dedicated to fostering the role of critical care pharmacists as essential members of the multidisciplinary patient care team. The Critical Care PRN's goal is to optimize drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, including how to become a member, go to critprn.accp.com. Again, that website is critprn.accp.com. Welcome to PharmacyToDose, the Critical Care Podcast, a partner of the ACCP Critical Care PRN and a member of the Pharmacy Podcast Network. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. So I made a one-day appearance to the Neurocritical Care Society annual meeting, and there was a plethora of pharmacist-featured research. So I'm so excited to be able to highlight the amazing work of our pharmacist peers and colleagues from the 2023 NCS annual meeting. So 9 pharmacists joined me to discuss everything from pharmacotherapy with neuroendovascular stents to augmented renal clearance to validating a VPA derivation equation, neurostimulant prescriptions in neurologically injured patients, melatonin use, and pharmacist participation in various scenarios. Now, a quick reminder of the format for pharmacist-featured research review episodes. So I'll introduce each guest, they'll give an overview of their research, and then I'll join them for a quick Q&A. The link in the episode description, it's going to take you to a post that will have all the research posters, right? So you can view them and then visualize what the guests are referencing. And maybe even more importantly, you all get to enjoy this research and you didn't have to go to Phoenix in August. So I think that makes you all the real winners. What an awesome episode. So let's get going. And thankful to be joined by recurring guest Casey May. And if you haven't yet, listen to the aneurysmal subarachnoid hemorrhage part 2 episode. Casey's an awesome guest host. And then reminder, Casey's a clinical associate professor at the Ohio State University College of Pharmacy and a neurocritical care pharmacy specialist at the Ohio State University Wexner Medical Center. And not only was this research presentation highlighted in the late-breaking science session at the NCS annual meeting. That's correct. Casey was on the big screen in the big auditorium, but it's also been published ahead of print in Neurocritical Care. Now, Casey May is the first author of this really like Neurocritical Care pharmacist collaboration, including a collaboration with the Neurocritical Care Society Pharmacy Study Group. And this study is entitled The Multicenter Comparison of the Safety and Efficacy of Clopidogrel versus Ticagrelor for Neuroendovascular Stents. So Casey, I think I spent long enough in the intro. Why don't you come in and let the listeners know what this study was and what you ultimately found?
Yeah, great. Thanks for highlighting the study. It's been a labor of love for me, so I'm excited to talk about it. So this study, we really set out to evaluate stent thrombosis at 3 to 6 months when comparing patients who are on aspirin and clopidogrel or aspirin and ticagrelor for their neuroendovascular stents. And just for those of you who are not super aware, there's not a lot of data when it comes to comparing these two groups. Also in just ticagrelor alone in neuroendovascular stenting. So we really set out to see if there was a difference that we could see in the long-term outcomes of stent thrombosis of these patients. So as you mentioned, this was a collaboration of the Neurocritical Care Pharmacy Study Group. So this is a multi-center. We include 12 different sites, retrospective study that was completed between the dates of July 2017 and October of 2020. We included patients in a reverse chronological order. So we went from the most recent into the oldest so that we can make sure we eliminated as much practice variation with respect to time as we possibly could. So ultimately, patients were divided between the two groups, between aspirin and clopidogrel and aspirin and ticagrelor based on their discharge regimen. So that's how we divided the two groups. When looking at our results, we actually screened over 570 patients between the 12 centers, and we included 360 patients in the clopidogrel group and 126 patients in the ticagrelor group. There were really not a lot of differences between the two groups when we started looking at baseline characteristics. The only thing that really was different between the two was that the clopidogrel group was actually more commonly having a planned procedure. And we can talk about that a little bit when we discuss kind of what we found. It was a wide variety of locations of where the stent was placed, as well as the type of stent or the type of procedure that was done. But ultimately, we found that there was no difference in stent thrombosis. And stent thrombosis was really a composite of the patient presented with new clinical symptoms of a stroke, or they had a stroke on imaging, so that stent was thrombosed and they could see that on imaging. So it could be one of the two or both. Ultimately, we found no difference between the two. Both had a stent thrombosis rate of about 8%. And so no difference there. Obviously, we're going to be concerned too with secondary outcomes of bleeding is mostly what we looked at, and mortality. And we saw no difference between any major bleeding, minor bleeding, or death between the two groups. Those were probably our biggest findings for like the primary and secondary outcomes.
So, I mean, labor of love is probably putting it kindly. What an endeavor, right? I think the biggest study to date looking at this. So kudos to all of you. Now, educate me, because I feel like I'm a little ignorant to this question, but what are like special considerations with like neuroendovascular stents compared to like dual antiplatelet therapy with like the classic like coronary artery stents?
Yeah, so, there are obviously different types of coronary artery stents too. The most common you think about would be, is it drug-eluting, is it not? But generally speaking, coronary stents are straight. And so when it comes to cerebral or neuroendovascular stents, they come in many shapes, sizes, and types. The biggest thing that we like to think about is comparing those patients that may have an ICA stent, which we know has a pretty low thrombotic risk, so just right there in the ICA, versus like flow diverting stents or other types of stents that would be more in the true like vasculature of the brain. And these stents are very thrombogenic, because if you think about the nature of the vessels in the brain, it can be very tortuous. And so these stents turn a lot and are generally much more thrombotic than we would even think of like a coronary stent. So when we put patients on stent, we're very cautious and cognizant of what their dual antiplatelet therapy looks like, and ensuring that it is what we would call therapeutic, which is something that we don't focus on as much in the coronary artery stents.
So it feels to me less like apples and oranges, and maybe it's not like apples and spaghetti, but maybe it's like apples and avocado, because that's definitely very different, right? Very different considerations and just kind of mechanisms in general. Now, you mentioned monitoring. That was one of my big questions was, if you are a center that routinely doesn't use platelet monitoring tests when patients are started on dual antiplatelet therapy, is there a signal from this that maybe we should consider using one over the other as a first line agent? Because I noticed it was a pretty high rate of platelet monitoring that happened in these groups in this multi-center trial.
Yeah, so, obviously these patients come from, large centers who do this pretty frequently. And so most likely this is representative of the actual patient population that we're seeing these neuroendovascular stenting procedures in. And as you mentioned, like, we aren't necessarily monitoring in coronary stents because there has been literature to prove that there's no difference. However, we do have some significant literature in the neuroendovascular space that if patients are not appropriately antiplateleted, for lack of better words, on their dual antiplatelet therapy, that it can lead to stent thrombosis. And so we do have literature supporting that monitoring is important in these patients. And so, yes, you are correct. We had nearly 80% of our patients in both arms had platelet monitoring. Why is this important? And I think when you look at the primary outcome of no difference between stent thrombosis, I think you have to kind of put the pin in that caveat that, yes, we saw no difference, but we had a very, very high rate of monitoring in both groups. But most commonly, this is targeting that clopidogrel, right? So we know that clopidogrel is a prodrug that needs to be converted into the active form. There's a lot of genetic mutations that can affect how that metabolism happens. It can happen that the patient has significantly more drug converted or significantly less drug converted. And so here you can actually see bleeding or thrombosis complications in patients with clopidogrel, which has been reported in the neuroendovascular literature. So yes, I think that if you are a site that is not monitoring, perhaps the first step isn't monitoring, but it's actually looking and seeing if you're having any problems with stent thrombosis. Maybe that is the first step, or just having a conversation with your providers of their comfort level with monitoring and, potential dose augmentation or switching to ticagrelor if a patient happens to be a non-responder to clopidogrel.
That's really great advice in a way to take this research and try to bring it back to your institution, right? And bring it into and see if or how this could get incorporated. So that's a really good advice there. The last question that I had, kind of stemming from this discussion of this paper, right? Neurocritical Care, everyone go download it, read it. But the patients in the ticagrelor arm, they had a higher percentage of emergent or unplanned neuroendovascular procedures. And in the paper, it says this wasn't an unexpected finding. Why do you say that? Why would this be something that was expected kind of going into this research?
I don't think that I expected it getting the results, but once finding the results and reflecting on practice, I don't think that it was surprising. So one thing that we found was that the majority of the difference between the two groups is that in the clopidogrel group, they're more likely to be planned procedures. In most of our practice who deal with these patients, we see that a patient has a planned stent, whether it's for, aneurysm, like prophylactically securing an aneurysm before a bleed. So we're teeing a patient up to get a flow diverting stent or a stent-assisted coil, or we're teeing up an ICA stenosis patient to get that ICA stent, right? So we're putting on the aspirin and Plavix. The thing about it being planned is that we have the opportunity to monitor and make sure that they're in that appropriate therapeutic window for the PRU if you're using the P2Y12 monitoring. And then we can either switch agents or dose increase or reduce, right? So we can make sure that they are teed up for that stent. So that part wasn't surprising. Now, the fact that, more of our patients had emergent procedures, and I think more specifically, there was a difference in the actual artery that was intervened on, so the basilar. So we had more patients in the ticagrelor group have the basilar artery intervened on. As we all know, this is a very important artery that supplies the only artery that supplies blood to the brainstem. You can have devastating consequences if you thrombose that artery. And so our surgeons or neuroendovascular interventionalists are not willing to accept the risk of a patient being a clopidogrel non-responder. And so in those situations, whether it's either an emergent stent placement and they didn't have time to tee the patient up on clopidogrel, or they're dealing with a very high-risk artery, they're more likely, in my practice experience, to just jump straight to ticagrelor to ensure that the patient is therapeutic.
That makes sense. Like once you, and I'm sure that's kind of, once you reflected back and thought about it, it makes sense. And that's kind of what my thought is as you explain that. So this is really cool. And, for those curious, pull up this supplementary appendix, and it gives a shout out to all the different centers, all of the other collaborators within the group. This is, it's as high quality of retrospective as we can, right? Multicenter, and it notes out, right? This is all voluntary basis, right? No funding was achieved. So shout out to everybody doing this, trying to improve the care out of the goodness of their hearts. So congrats on a job well done. Reach out to Casey, let her know at Casey May PharmD. Thanks for coming back, Casey. We certainly appreciate it.
Yeah, thanks for having me to continue to talk about, my this is definitely in that subarachnoid window as well as where this kind of started. But yeah, thank you very much. I appreciate it.
This is on the Mount Rushmore of Casey's neuro topics right there. All right, so we got 2 out of the 4. All right, we'll keep searching for the other one. So listeners, you're going to be the real winners there. All right, see you, Casey.
Thanks.
And joining us now all the way from Canada is Sherif Mahmoud. Now, Sherif is an academic associate dean and clinical professor in the Faculty of Pharmacy and Pharmaceutical Sciences at the University of Alberta. Find him on Twitter at Sherif Elezaby, SherifElezaby. Thanks for joining us today, Sherif. How are you doing?
I'm doing great. How are you, Nick? Thank you.
Doing fantastic. So let the listeners know about this awesome Neuro-ARC study, and then we'll get into our Q&A afterwards.
Okay, perfect. So that study is titled Prevalence of Augmented Renal Clearance in Neurocritical Care Population, a prospective multicenter study. In short, I call it the Neuro-ARC study. It's so in summary that augmented renal clearance, or ARC, is a recently described phenomena of enhanced kidney function. And this has been reported in critically ill patients. And the issue of enhanced kidney function is actually super kidneys. And the super kidneys might result in underdosing medications that are renally eliminated and might result in therapy failure. That's why the attention is being given in this work. However, most of the ARC literature hasn't focused on neurocritical care patients, and ARC is largely undetected using the common creatinine clearance equations like Cockle-Gold and others. And because of that, we need to find a way to identify ARC. One other thing in the Neuro-IC specifically, is actually the smaller study showed that the percentage of ARC, the prevalence of ARC in those patients is way higher than the critically ill, as I've seen the results of the study. So there is a need to identify the true prevalence and risk factors of ARC. And try to find a way to identify this. So the overall goal of this study is to characterize the prevalence and risk factors of ARC. It's a prospective multi-center study at the University of Alberta Hospital, University of Kentucky. We recruited so far 70 patients. We plan to recruit more than 500 patients in a larger study. And we will measure their kidney function, their creatinine clearance, using the 8-hour urine collection. We did the 8-hour urine collection and to identify who have an ARC as by definition creatinine clearance more than 130. We found that those patients who exhibited ARC are younger, more males than females, have less disease severity as well. And we enrolled patients with subarachnoidal hemorrhage, traumatic brain injury, and the percentage of ARC for those patients ranges from 90 to 100%. However, we did also intracerebral hemorrhage and status epilepticus ranges from 33 to 85%, ischemic stroke 70%. So as you can see, the numbers are way higher than actually what's reported in the general ICU population, which is approximately 30 to 40%. So in summary, we have found that ARC is highly prevalent in those population, and probably this underlined the fact that we need a way to identify those patients for better outcomes.
Well, first off, what an awesome study. Your first author leading names that are certainly familiar names to listeners of the pod, Melissa Thompson-Bast and Aaron Cook. So clearly you have an amazing research team with you. So kudos. Now, I want to ask a question because I think when you hear the phrase urine collection, right? Even if it's just 8 hours, everyone instantly just puts their hands up like, we just can't do it. It's too much. So, but is this the only way? Are there other alternate ways to reliably identify that augmented renal clearance?
Yeah, I agree. Urine collection is not really practical in a busy environment in the ICU. And so in day-to-day practice, we don't do it in our center. So, but what the main aim of this study, we need to identify the risk factors of ARC in those populations. By identifying those risk factors and prevalence using that urine collection, which is kind of the gold standard in the ICU, we'll be able to identify predictors of ARC. What does this mean? So after we finish the whole study with more than 500 patients, we'll be able to create a prediction model to tell me if this patient has a certain age and sex and these characteristics, this is a very high chance this patient will have an ARC. So some sort of a prediction model, a tool, we'll create a tool, when the patient gets admitted to the ICU, we'll be able to know what are the chances the patient has ARC instead of going into the urine collection. Unfortunately, the current creatinine clearance equation for estimation of creatinine clearance equation, they underestimate the true prevalence of ARC. So hopefully, after we finish that study, we'll be able to find something that will provide, create a tool that helps identifying those patients.
So what I'm hearing is hopefully soon we will have a more reliable way to calculate these. But right now, if you're truly worried, that urine collection is truly the way at this point in time for all of us. True?
Agreed. Yes.
So knowing we can't always accurately estimate renal function, how should we use this information that you just talked about, right? That the prevalence of augmented renal clearance in a neurocritical care population could be in the 80 to 90%, right? This one found 84%. How do we use this information when we're creating those empiric dosing regimens in these patients, knowing that we think it may be high, but we don't always know how high are things realistically as we're creating these?
Yeah, great question. So currently there are studies looking at the pharmacokinetics, the measuring the drug concentrations of many of the commonly used drugs in the ICU, and those studies provide some suggested dosing recommendation. However, as a part 2 of our study, which actually what we are currently doing is we are collecting blood samples for patients treated with many of the commonly used renally eliminated medications. For example, levetiracetam, the piperacillin, tazobactam, cifibime, and so. So once we collect those levels, we collect those blood samples, we analyze their concentration, and what we do right now is once we collect, have a good sample size, we'll be able to do pharmacokinetic modeling and simulation. In order that simulation will simulate what dosing needed in order to achieve the desired target. And once we know that, we'll be able to provide dosing recommendations, solid dosing recommendation. But I'm not going to be only focusing on our study. We'll also get into consideration other studies that do the pharmacokinetic sampling and did the simulations, and we'll combine them together. So at the end, we'll have solid dosing recommendation. But for the current being, actually now, some medication monographs and some software, they provide some dosing recommendation in augmented renal clearance. However, they more work needs to be done in this area.
So this last question I feel like is so much easier asked than done. But when do you all anticipate the larger study completing, knowing that there's a lot of things that need to continue going right for that to happen? But what's the anticipated date? When can we look for those results of the bigger study?
Yeah, that bigger study is duration is approximately 5 years. Hopefully, we get complete results by the end of 2026, early 2027.
Well, we'll keep our eyes peeled, but this is really awesome preliminary data. I'm glad you took some time to come on and highlight this. And of course, if you were at the Neurocritical Care Society annual meeting, you saw Sherif's name all over the place, presenting, headlining things. So thanks for all you do for us in that neurocritical care and pharmacy world, Sherif. We appreciate you.
Thank you so much, Nick, and thank you for having me.
Now, with us now is Ji Liu, currently the trauma ICU pharmacist at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Ji, thanks for joining me. How are things on the East Coast today?
It's a little bit rainy, Nick, but things are so far so good. So thank you for having me, inviting me on the pod. So.
The pleasure's mine. I'm excited to have you come on, and let's talk about your research project, derivation and validation of an equation to predict free valproate concentrations in intensive care patients. So, G, take it away.
Yeah. So thanks, Nick. So this is I think a very important topic because valproate remains a very highly used anti-seizure medication with an expanded indication for bipolar disorder, for migraine, and obviously for seizure. And occasionally in ICU, we use it for behavioral management as well. So really, if you allow me to kind of set a background on this, because valproate still remains a widely used medication, and we know that from the pharmacokinetic of valproate, it's highly protein bound, and we know that 90% of the valproate is protein bound to albumin, with 5 to 10% of the concentration being unbound. And it's very important to note that the free or unbound valproate concentration is the pharmacologic active component that is kind of responsible for the toxicity and also for the efficacy of the drug. So this is based on the old paper. Just in terms of therapeutic drug monitoring, we found that not a lot of centers do a lot of free valproate monitoring on site. So therefore, there's been this interest in doing equation-based models in an effort to kind of get free valproate. And we know that ICU patients are more at risk for altered protein binding, and there's been increasing literature to show that ICU patients really see much higher free fractions, ranging from all the way from 15 to 89%. So what we did with this paper and with this research study is to kind of look at all the equations so far that's been trying to kind of use to estimate free valproate. And we did a literature search, and we are able to find 5 equations. And we asked the questions like how good are these equations in terms of estimating free valproate in ICU patients, because all 5 equations are from non-ICU, mostly in the outpatient setting. So really the objective of our study is to first validate the existing equations and assess their performance in ICU patients, and then to compare its predictive performance to novel equations just derived from our cohort of ICU patients. So the way we go about doing that is to include this is a 2-center study, both at Mayo Medical Center and at Mayo Clinic, and we included patients over 18 or above who had both free and total valproate concentration collected, and we also collect other laboratory values such as their albumin, their blood urea nitrogen, creatinine, and bilirubin. These factors have been reported to affect their protein bindings of valproate, and therefore may affect their free valproate fraction. So essentially what we did was we divided the patient into 2 cohorts. So we used a derivation cohort to derive our equation, and we included a separate cohort to validate our equation. And we use the modified Plan-Elman plots. So for those who may not be as familiar, it's essentially comparing your estimated valproate, free valproate to the actual measured valproate concentration, and you will see two measures of to kind of indicate the performance of the equation, which is the bias, or how accurate your equation in estimating the patient's actual measure free valproate concentration, and then there is this how precise or the equation is. So we reported that the main findings of our results is that all existing equations perform pretty poorly in estimating free valproate concentration in ICU patients with the mean bias of 2 all the way to 9. So kind of depending on the reference range you look at, commonly cited will be 5 to 15. So definitely these equations are not very accurate. And also in terms of precision, these equation, we also found that it's not very precise with, the limits of agreement ranging from anywhere from 16 to 11. So definitely not very useful in clinical practice. In terms of the equation that we derived from our cohort, we found that even though our equation had, a bias of 0.3, we found that the limits of agreement is pretty wide. So therefore, more work is definitely needed to find an equation that kind of for centers that may not have this ability to measure free valproate or get timely valproate level. More work is needed to kind of find some find that equation to estimate free valproate concentration.
Well, Ji, this is awesome research. I have a few questions because this is a really timely topic. I think it's something that all of us in the ICU, we talk about, we struggle with sometimes. So looking at VPA levels, how does timing, specifically when they're drawn, how do you think that affects the interpretability of the equation?
Yeah, very good questions, and definitely important question to ask whenever you see any equation-based models to kind of estimate valproate. So, what's their practice like at different centers? Like, do they measure free valproate and total valproate after the load or for a trough and things like that? That definitely impacts the interpretability of the equations. So, for our practice, we want to say that we typically will avoid post-loading levels. So therefore, we did not get the specific. We do not have the specific in terms of this number of patients getting post, a steady state, or because in clinical practice, it's often not feasible to wait until steady state to get a total and free valproate level. So, but just speaking of practice, most of our the levels included will probably be before like a 1 hour before the trough. 1 hour before the level is due, but we typically avoid post-load levels.
So you've clearly not only done research into it, but when you do research, right, you do a lot of looking into background of things, right? So in your opinion, why do you think we're having such a hard time finding a validated equation to predict free valproate concentrations from total levels in the critically ill?
Yeah, and that's another important question to answer because, not just valproate, right? But, we've seen that story in phenytoin as well, like how many equations and modified equations and follow-up studies on phenytoin and trying to kind of get that, get a good equation to estimate free phenytoin. And it's a question that as I was doing this research and talking with our team that, it's difficult, right? Because we are trying to, get an accurate estimation of a moment in time, right? Most of these things, like for example, our study, we included just one set of levels, total and free, right? But we know that at least in ICU patients, things change. So if I allowed me to give an example, for like an ICU patient who's on very high dose of propofol, where propofol can, free fatty acids can bind and potentially displace valproate from the albumin binding site. If a patient's on higher dose of albumin, or if they're also in renal failure with high uremia and other risk factors, that a patient with that many risk factors could potentially have a higher free fraction of valproate and therefore resulted in a higher free valproate concentration. However, not all ICU patients are kind of the same, right? So if a patient who is just there for monitoring in the ICU where they may not have those risk factors, then you may imagine that why having one set of equation may not be applicable to these two kind of patient scenarios. So I think that's why we kind of struggle in terms of finding an equation that works well in just all ICU patients. So just to speak a little bit in our cohort, unfortunately, our cohort did not include a lot of patients on propofol, and initially we went in thinking including a patient on intralipid, but however, our patient population also consists of very low patients on like TPN or fat emulsion and things like that. So statistical equation is definitely underpowered to detect those differences. So ongoing efforts definitely needed to kind of include those patients with more of those risk factors to see, and more work is definitely needed to externally validate the equation that we put forth.
I think propofol is such a great example too, because the patients that we're going to be wanting the most accurate free level in, right? They might be on high dose propofol for refractory status, right? Or they're on very high doses for like burst suppression or something like that. So I think that's a great example, and their time courses change, right? They might be on 50 mics per kilo per minute one day, and then 3 days later, they're down to 20. Should we be changing our regimen? So
exactly. And most of these equations, they divide, like you use one set of levels, right, for patients at one moment in time. And I think that's why it's very difficult. However, it's an important endeavor we believe in still. I mean, by all means, that we should kind of work with your lab to get free valproate insight, try your best. But I think if that route has been already tried and still we'll run into limitation, and that's the real life experience where we might not get all the things that we want, right? And because we're occasionally practice in like resource limited settings. So therefore, endeavors like this, I think still worth pursuing, so that in like community hospital or it's physically or it's not feasible for them to get these monitoring, and it's important thing for clinicians perhaps to use in the meantime for these patients.
That's an important point, talking about places that maybe don't have these on site, right? So as people are advocating, as awesome researchers like you are trying to find equations and things for this, what would you recommend for those institutions if their lab doesn't have the capability for those timely levels? Like say a level is going to come back in a day or two, like a free level. Is there any utility in ordering that? Like what kind of pearls or things can you give for some of those other institutions?
Yeah, that's a very good point. So I think, first, like I already mentioned that, definitely work with your lab to see if to explore that possibility. If there is a possibility that you can bring free valproate, definitely I would definitely support, attempting that first. However, if that's not a feasible route, and we know from data that's kind of older that, only like, I want to say like 3% of the laboratory in the United States actually offer assays or free valproate. And recently we did, I think we put out a survey on AHCCP, and mind you, not all the centers are participate in that survey, but overall we still see a pretty low percentage of hospitals that actually have the capability of measuring free valproate in-house. So definitely we see that the centers are still not getting that. So therefore, it's one of the reasons why we're pursuing this research project to put out that put this forward. And but to answer your question, Nick, is it are there utility to measuring it? I think so, especially from our data that, with all the existing equations, right, overall we found that because these equations are not derived and, in ICU patients, we found that the performance are really not great, right? So definitely even if it doesn't come back in a day, it's definitely a utility in measuring that free valproate levels, even though you might come back and maybe not the same day for 2 or 3 days. And I would suggest that, once the patient, evaluate the patient's risk factors, especially if the patient's on like higher dose propofol, or if they have uremia, like, BU, high BU and other risk factors, then those would be the patient that I would definitely want to check a free valproate level. And that might subsequently, even if it comes back 2 or 3 days later, that might still impact your dosing, especially if this is a drug with a narrow therapeutic index. I will consider, right, in the meantime, you can consider using our equation. Our equation is definitely limited by the Y limiter agreement, but however, it does have the lowest bias of all the existing equations. So one thing I would consider doing is that, we can use our equation to estimate free valproate and send out an actual measure the patient's total and free valproate and see how the equation perform, right? So if you actually find that it's actually pretty close, then whereas you can kind of validate, this equation is not working for this patient because it's not one of the patients that will be well represented in our cohort, or if the patient is actually like, we're spot on, right? So that's kind of important information. So definitely our equation should be used very cautiously because it definitely requires more external validation. However, it should be used kind of like as a mark for estimation, and if the measure free valproate actually kind of coincide or very closely with the estimate of VPA equation, then that's a kind of a good signal that maybe for that patient it is represented. So yeah, I don't have a great answer. I think this is still like a kind of a lot of efforts need to be kind of put into this to kind of, I think one of the most important research question moving forward is, so free valproate ranges, right? Like what are the actual free valproate we should be targeting? Like we use these reference range of 515, 517, depending on what you looked at, but we definitely need more rigorous research in terms of interpreting like what are actually efficacious concentration, toxicity, free valproate concentration that needs to be further elucidated in further research.
Well, for the listeners, right, go to PharmacyToDose.com. You'll see, we'll have a copy of the poster up. So that equation that he's referencing, you'll be able to see that. And I mean, you gave the listeners not only one, but two options to consider as we're figuring this out. So there's not a perfect answer, right? But we're trying to find the best fit line, and we have a few options to try to do that. So, Ji, thank you so much for sharing this awesome research, for continuing to do this, and for coming on the pod and letting all the listeners know about it. So we appreciate you very much.
Yeah, thank you, Nick, for offering this opportunity, and thank you for all the work you do. And I would just want to give a shout out to, my mentor, Dr. Dave Gannon and Dr. Riker for, and also our entire team for, giving the support on this. It's been a long process, so it won't be done, without them. And they offer so much insights, and we are looking for on collaboration on this. So if your institution does have a lot of free valproate concentration or have the capability to monitor free valproate concentration, definitely reach out to me, and we're looking for more collaboration on this to kind of externally validate our equation and definitely look into the ranges and toxicity and whatnot. So thank you.
Now, our next special guest is Veronica Bonderski. Now, Veronica is a neuroscience ICU clinical pharmacist specialist at the University of Chicago Medicine. Find her on Twitter at Veronica B PharmD. Oh, that's got a fun ring to it. Hello, Veronica. How are you doing?
I'm good. How are you?
Doing great. Thanks so much for joining to highlight the awesome research that you presented at NCS, the effect of IV push, levetiracetam, and lacosamide implementation on turnaround times and cost. So I'm going to let the floor is yours to kind of give us an overview of this study and talk about what you all found.
Yeah, thank you so much for having me. So in March 2022, our institution made the decision to switch over administering our IV levetiracetam and lacosamide doses as an undiluted IV push, as opposed to a dose prepared in the IV room We did that, as all the data has come out in the last few years about the safety of this practice. We went ahead and decided to go for it. So the purpose of our project was to look at and see if our turnaround times for when the providers were entering the doses into Epic to when they were being charted and administered, if there was an improvement in that. And then we also wanted to look at if there was cost savings associated with this intervention. So we looked at 11 months prior to us implementing this practice change and 10 months after, and compared those times and costs. We looked specifically at one-time doses of both of these medications because those, as you know, tend to be the stat one-time loading doses during emergencies, and we didn't think that we were going to end up actually seeing that much of a difference in the scheduled doses. So we wanted to look at those one-time doses, and we looked at all of our patients, all adult patients within our hospital. Our primary endpoint, like I mentioned, was time from order entry to medication administration. We also looked at those drug costs, and then we also did a retrospective review of all the safety events that were submitted by our nurses, pharmacists, and physicians, what have you, to see if there were any kind of red flags that we needed to address as time went on. So when we looked at the doses of IV levetiracetam prior to administration, prior to implementation, we had 510 one-time doses, and the median turnaround time was 81 minutes. After we made that change, our turnaround time house-wide was a median of 24 minutes. For lacosamide, we saw similar trends. For house-wide, we had 73 doses prior to the change, and the median time to administration was 128 minutes. After implementation, we got that down to 41 minutes. So we were really pleased with how this went. And when we broke it down into emergency department doses and doses given in our neuro ICU, we saw similar trends kind of in those subgroups. When we looked at the safety events that were being submitted during this kind of change, we didn't have any lacosamide events, but we did see levetiracetam events come through. We had 4 related to stocking out in our Omnicell, which was an easy change. There was a little bit of growing pains as we figured out where this drug needed to be stocked and what the PAR levels were. But we also had 5 events related to ordering errors and administration errors. And the reason for that was when we rolled this out, we decided we were giving levetiracetam doses as an IV push all the way up to the 4,500 milligram max dose. And in order to kind of capture the USP 797 concerns associated with this, we originally split out the orders and created an order set that broke each dose into 1,500 milligram aliquots, or, rounded it to things that made sense. So, for example, a 3-gram dose was 2 orders of 1,500 milligrams back to back, or a 2-gram dose was 1,500 followed by another 500. And what we were finding is that occasionally the nurses were interpreting this as duplicate orders, or the providers were getting a little confused when they were trying to order it and would try to modify it in Epic, and then the incorrect dose ended up getting ordered. So what ended up happening was we took this back to our med safety team, and they actually allowed us to change over to single syringe administration for all of the doses. So that is something that was going on in the background while we were making this change that could have influenced some of our numbers, but just wanted to throw that out there for any other institutions that are looking at making this change. And then lastly, we looked at costs. There was no difference in lacosamide costs. We kind of think that's probably related to it being a controlled substance, and we definitely have a tighter control on where those doses end up throughout the hospital. But we definitely did see some changes for levetiracetam. We captured this by looking at what our percentage of WAC purchasing that we had pre and post implementation. And the reason we did this is because we actually had a very large uptick in IV levetiracetam use after we made the change. There's a couple of reasons why we think this happened. One, our trauma volumes exploded. So we were giving a lot of one-time pepper doses in the emergency department. And also not entirely sure that all of the one-time doses were captured in that initial phase, because we did exclude any doses that were made by an ICU pharmacist or an emergency medicine pharmacist at the bedside, because that was something that was going on. We had some vials stocked in other places before we made this big change, and people were compounding bags at bedside. So it was hard to get like a firm dollar amount, like this is exactly how much we saved. So how we quantified this was our WAC purchasing. So prior to implementation, 42% of our purchasing for levetiracetam was going to WAC, and now it's 28%. Like I said, I couldn't get a hard number, but ballpark, that was about $1,500 to $2,000 a month we were saving on IV levetiracetam for our institution. So overall, really happy. We saw some definite improvements in our turnaround times, and the cost piece of it is always a bonus. So we're really, really happy with how this all went.
Yeah, kudos on almost a 3 times reduction in time to administration from order entry. That's so great, and I love that you highlighted. I think if you had to take a poll nationwide of pharmacists, I would say more than 50% probably have a specific drawer reserved for some sort of stat drug. Is it Keppra? Ours is like PCC. We'll keep the supplies and stuff are there. So I think everyone has things there now. You mentioned around this time we've had a lot of literature kind of being published on this same change. Was it the literature itself, or was it more specific things like the needing to kind of hole away drugs and things that led to this change from IV piggyback to IV push?
Yeah, it's a great question. I think it was a combination of both. I know all of us in the ICU and the emergency department, we're always looking for ways to get drugs to our patients faster. And I think we were already looking into how to do this and making changes in other areas of the kind of the workflow. And then once this data came out, that was kind of like the final push to go ahead and bring this to our, kind of administrative group and try to push it through.
And I think that was a really good example of when you talk about the change in IV push of a lot of times you'll when you roll out a new policy or protocol, there's something inevitable that you're unable to think about, especially when it's electronic order entry and things. So did you all have a plan to like reevaluate this at a specific time, or was it one of them where like you all just kind of saw one of them, or a couple docs came to you and then it was a snowball effect from there?
Yeah, when we originally took this to our med safety committee, we did have a plan to follow up and kind of re-report our findings a couple of months later. But as it was rolling out, we did also get kind of those one-off questions from our nurses and providers, which was great because then we were able to have kind of boots on the ground experience and from them that we could take to med safety when that kind of the official review was up. So it was a combination of both. Before we rolled this out, we did reach out to other centers and try to see, what kind of problems they had to kind of keep an eye out for. But like you said, there's stuff that always comes up, and this definitely happened for us too.
Well, this is such a great study. I mean, you're talking about reduced time to administration in these time sensitive disease states and things. You're talking about saving costs. Now, Veronica, we only need one thing. And we need the manufacturers of Keppra or levetiracetam to make a frickin' 4.5 gram vial, so I don't feel like Saint Nick with a stocking when I have to go do the 4.5 grams. I got 9 vials in my pocket that you're going to the room. So that's the next move we need. That's the only you've made significant progress, but when we've made that change, we'll have you back on, Veronica, to really tout the total victory. But what an awesome research project. So glad you took the time to share the results with us and these ideas. So appreciate it.
Yeah, thank you so much for having me.
And our next research highlight is what we like to call a twofer. We are very lucky to be joined by 2 guests. We're going to be focusing on one of their research presentations, and we'll kind of hit on one of their others. So I'm very lucky to be joined by Solomon Almahaish and Gretchen Brophy. Now, Solomon is an assistant professor at King Faisal University, the College of Clinical Pharmacy, and an affiliated neurocritical care researcher at VCU School of Pharmacy. And Gretchen Brophy is the professor of pharmacotherapy and outcome science and neurosurgery. Thank you both for joining me, taking time out of your day. How are you all doing?
Thank you. Thanks.
Thank you.
So what were the research we were going to try to highlight today, neurostimulant prescription rates in patients with neurologic injuries. So, I know Solomon's going to be taking the lead on kind of giving the overview, and then Gretchen and Solomon will both be tag teaming questions and those kinds of things. So Solomon, the floor is yours, my friend.
Well, thank you, Nick. Thanks for having me on your podcast. So, for this study, we know that neurostimulants have been used in multiple neurological injuries, and we know that there are so many neurostimulant agents have been used. So our question came is which one has more frequency of prescription rate compared to the other in each specific neuro injury. So we went through the Virginia all-payer claims data, try to include all patients with a prescription for neurostimulants for specific neurological diseases such as TBI, ischemic stroke, and intracranial hemorrhage, and also subarachnoid hemorrhage. So we tried to include all of these patients between the period of 2015 to 2021. We looked into prescription rates or any new prescription for after the discharge from the hospital. Until 90 days of the discharge. So we tried to include all of these new prescriptions, and we were fortunate to include 2,787 patients from around 1.5 million cases or patients. So we included these cases. The most frequent injury type that we saw was ischemic stroke and traumatic brain injury compared to other neurological injuries that we mentioned previously. The most commonly prescribed agent was zolpidem. After that was carbidopa, levodopa, and amantadine. So the three agents came up on the top. Amphetamine was also, and methylphenidate were one of the top drugs with around 9 to 7% for both of them. We didn't see any trend throughout the years between 2015 to 2021. The trend was almost the same between all the years except a single year, which we think was a flaw in the data for the all payers data. For the traumatic brain injury, the most commonly prescribed agent was zolpidem. After that, the carbidopa, levodopa. And methylphenidate had 9% prescription rate. Amphetamine or amantadine had a 9% also prescribing rate. That's for the ischemic stroke. For the traumatic brain injury, zolpidem had 25% prescribing rate. Amphetamine had 17% of prescribing rate. So these two also agents are for one of the top agents that were prescribed. We know that there's some co-founders that could happen with zolpidem, as some of these cases may have been prescribed zolpidem for sleep disorders, not only neurological injuries. So that could be the case with the high frequency of these prescription on zolpidem compared to other usual neurostimulants such as methylphenidate and amantadine. So our conclusion was we didn't find any significant difference between the years, but we were able to tell that these agents were mostly prescribed in all of the neurological injuries that we looked at.
Yeah, and I would just like to add, in these patients, there's never been anybody, or there's never been any data really out there on, which patients are receiving the neurostimulants and if there's any trends in what's prescribed. And that's another reason why we wanted to do this study. And we did look at multiple different neurostimulants. And within our data set, just to add, the ischemic stroke patients, we had the most ischemic stroke patients in this data set. And then the second most highest was the TBI. So when we're looking at the drugs and the percentages of the different agents used, That's why the ischemic stroke patients probably had, more just because we had more patients in that group. We did see the difference, as Solomon said, within the agents that were prescribed. So with methylphenidate, amantadine, and amphetamines, which we usually think of as neurostimulants, that we would use in somebody with a neurologic injury. We actually saw those in the traumatic brain injury patients more so than we did in ischemic stroke patients, which is something we would have guessed, I think, that would have been the case. With the zolpidem, it was very interesting just to see that was the top drug used in both cases. And as Solomon said, we included it because it actually can have paradoxical awakenings in patients. And so we thought that might be something we would see, but again, with it being so high, we probably assumed that was probably used for sleep, which is another very interesting point for these patients with neurological injuries, in that 25%, of the drugs prescribed to them of these ones that we looked at were zolpidem. So probably a lot of these patients are having some sleep disturbances as well, which is common with some of these neurologic injuries. So it's the first study really to show us up in the trends for neurostimulants in these patients with neurologic injury, and we're hoping now to dive into this a little deeper and see if we can use this database to quantify a little bit more about what's happening in our patients in regards to neurostimulant prescriptions.
Did these results surprise you, whether it's the patient populations that were the highest or zolpidem being the highest drugs? Like, was that a surprise to you all?
I think zolpidem being up on the top was a surprise, but then when we went back to think about these cases and everything, we started to dig down and feel like, yes, maybe most of the cases were prescribed zolpidem because of the sleep disturbances, not truly for the stimulant effect of the zolpidem. So we started to think about this, like going back to the data and maybe try to exclude these patients and get the true number of zolpidem as well. So that's part of it in our mind. We were, yes, thinking TBI could be up in the top, but as we looked into our demographics, we saw both actually TBI and acute ischemic stroke are on the top of our patients. So based on that, we thought, okay, then it tells everything in here that probably neurostimulants is in both of them, not only in TBI cases.
Is there a way in this database to determine what were pre-existing prescriptions compared to what were new prescriptions maybe started as inpatients?
Yes. So when we started to plan for the study, we tried to take this into account, and we basically excluded all patients who had prescription for a neurostimulant before the date of the admission. So anyone who had a prescription for a neurostimulant 90 days before the admission or to the hospital was excluded, to just get a true feeling of patients with a new prescription of neurostimulant after 90 days of admission. So we wanted to take into account these new cases and new prescriptions.
What a great job. I mean, characterizing, like you all have said, this is the first time we kind of have data like this. So awesome work. I love the insight there. Now, we teased at the beginning that you all had not one, but two research posters here to highlight, which is awesome. So I mean, give us like a little brief overview of the second one.
So the second one was a post hoc analysis of vitamin C study we did on our TBI patients. The first study, we tried to look into vitamin C levels in our TBI cases. And after that, we started to think about, okay, what about looking into patients who actually received statin therapy at home and continue to be on statin on admission or on hospital, and take into account, look into their biomarkers. Have these statin actually helped with the inflammatory process in TBI patients or not? So we separated patients to two groups, statin versus not. Tried to look into anti or inflammatory biomarkers, and such as interleukin 10, interleukin 8 and 6, and TNF alpha. We saw interleukin 10 is a anti-inflammatory interleukin. So we were thinking that interleukin 10 would go at least up with the statin patients, but we didn't see any difference. But with interleukin 6 and 8, we saw a decrease for statin patients, and both of these, interleukin 6 and 8, have been associated with poor outcomes for TBI cases. So that was a good thing to recognize in this study. We decided to take it out and make this poster and show the people out there that maybe statin have a beneficial effect with TBI. However, due to our small sample size and GCS of 15 for most of the cases, we weren't able to measure something clinically different between all groups.
Just to clarify, this group of patients that we used for this study, again, they were patients that had non-penetrating traumatic brain injuries, but I had a positive CT scan. So it wasn't like they were mild that were just discharged from the hospital, even though they had GCS scores of 15. We did exclude patients, though, with polytrauma just to try to eliminate some of the confounders of the polytrauma that would have on these interleukin levels. And so we feel like, the lower pro-inflammatory interleukin concentrations that we did observe, in the statin group shows some trends that, may be something that we continue to study in the future.
And to add to Gretchen as well, so also most of the the most frequent agent that was used on these patients was mostly atorvastatin. So if we would think about intensity, it would be somewhere between moderate to severe to high intensity statin. But this is still all like in a small group of patients, and we can't tell 100% if it's truly related to atorvastatin by itself or a different statin as well.
Well, Solomon, Gretchen, thank you so much for joining us, letting the listeners know this awesome research that you all presented at NCS, and clearly awesome things coming from Richmond. So appreciate all you all have done for us in the pharmacy and the neurocritical care world. So appreciate it.
Yeah.
Thank you.
Thank you very much.
So joining me now is Madeline Mitchell. Now, Madeline is an internal medicine pharmacist with the University of Louisville Hospital in Louisville, Kentucky. Find her on Twitter at Madeline M. Mitch. Madeline, thanks for joining me. How are you?
I'm very good. Thanks for having me today.
So I have to ask, right, we're neighbors in a sense, Louisville, Indianapolis. So if I would have pronounced it, right, Louisville, which all the Kentuckians are like cringing listening, would you have corrected me? I'm just curious how strongly the Louisville versus Louisville bothers you personally.
Yes, I definitely would have corrected you. I've only been here for 2 years, but I've definitely learned the slang, and I would have corrected you. But you hit the nail right on the head.
Love that. All right. First test passed. All right. Well, thanks for joining us. I'm going to give you the floor to talk about your awesome research study, the effect of melatonin on the use of antipsychotic medications in the intensive care unit.
Perfect. Thank you again, Nick. I also just wanted to say a shout out to my research team, Lindsay Whitecamp, Kristen Livers, and Rachel Lewis. They also played a big part in this research project. But as you all know, delirium is common for our patients that are admitted to the ICU. I always say there's plenty of better places to sleep than in the ICU or simply just really the hospital in general. It's thought that the risk of delirium is increased among patients with circadian rhythm disruptions and poor sleep quality, hence why melatonin and its effects on the regulation of circadian rhythm is an appealing treatment option in the setting of delirium. In previous literature, melatonin has shown conflicting results when studied for sleep improvement and the prevention of delirium in the ICU. And the current PADIS guidelines make no recommendations for the use of melatonin in the ICU. So really our mainstay of therapy for delirium continues to be antipsychotic medications, but there are risks associated with these, right? Especially in comparison to the safety and tolerability of melatonin. The purpose of our study was to evaluate the effect of melatonin on the use of antipsychotic medications in the ICU, specifically in the neurological ICU population, which may be predisposed to delirium. This is a single-centered retrospective case control study looking at a total of 200 patients admitted to our neurosciences ICU here at U of L Hospital. We looked at about a 2.5-year time period, and patients were excluded if they were taking an antipsychotic medication prior to admission or had suspected alcohol withdrawal. Majority of our patients included were around 60 years of age or older. They were mechanically ventilated, with most of the common diagnoses being intracranial hemorrhage and ischemic stroke. Our primary outcomes included incidence of antipsychotic medication use and total daily dose of antipsychotic medications, which we calculated as quetiapine milligram equivalent. We also looked at a variety of secondary outcomes related to length of stay, time to initiation of both antipsychotics as well as melatonin, adverse effects, and the continuation at discharge. Our results of the study showed that melatonin did not significantly alter the use of antipsychotic medications or daily antipsychotic requirements. The incidence of antipsychotic use was similar among groups, with about 45% in the melatonin group and 46% in the control group receiving an antipsychotic during their admission. The median daily antipsychotic dose in quetiapine equivalents was 43.8 milligrams in the melatonin group and 50 milligrams in the control group. Given the retrospective nature of our study, melatonin doses were not standardized, but the median melatonin dose administered was 5 milligrams daily. And in our subgroup analysis, patients on melatonin doses 5 milligrams or greater were observed to have a lower median daily dose of antipsychotics, although we did not find a statistically significant difference in this. Another interesting finding I wanted to be sure to touch on, because I wouldn't be a true internal medicine pharmacist without talking about transitions of care. Our study did show overall high rates of continuation of antipsychotics at discharge in both groups, with 27.5% in the melatonin group and 37% in the control group. Although continuation may have been appropriate in a few of these cases, it is worth noting given the potential long-term adverse effects of antipsychotics. So discontinuation of antipsychotics at discharge, or even when the patient's being downgraded from the ICU to the floor, I think is a very key intervention for pharmacists to really optimize our transitions of care.
Well, what a great study idea. I think my first question that came to mind, going through the paper, I'm curious because one of the statements on the conclusion said that, there was a patients getting greater than 5 milligrams of melatonin. They showed a lower non-statistically significant daily dose of antipsychotics. But based on what you've seen here and the research that you've seen, do you think patients should receive more than 5 milligram as our empiric melatonin treatment dose? Should we be going to like 6, 9, or 10, or what do you think?
Yeah, so the optimal dose of melatonin is unclear, and really in our previous literature also utilizes a variety of different dosing strategies, even differing from our study here. I did want to note, though, we wanted to tease this out in our study a little bit more, but our institution only stocks 1 milligram, 3 milligram, and then 5 milligram tablets. So the ordering strengths were a little limited, and our pre-built orders in our current EMR are usually 3 milligrams and 5 milligrams. So that's kind of what we thought was kind of why the median dose was 5 milligrams, just for ease of ordering. But yeah, you're exactly right. So although we didn't find a statistically significant difference with 5 milligrams or greater compared to lower doses, we did see a trend towards lower antipsychotic dose requirements. So I would probably recommend at least 5 milligrams, if not 10 milligrams, given melatonin is relatively benign, it's well tolerated. But I also wanted to add we have to consider that the potential confounder here is that melatonin is not regulated by the FDA, right? So the composition and potency can't necessarily be guaranteed from the products we have at our institution compared to the next institution.
Yeah, that's a really good point. You could certainly see pharmacist fingerprints if orders were getting changed to greater than 5 milligrams, because most of the time, if it's not the pre-orderable button, a lot of people assume that's the max dose. So shout out to the pharmacists that I'm assuming were involved in some of those. You mentioned you converted everything into quetiapine equivalents. So how were you able to do that? And then what was, in general, your most common antipsychotic that was used in this study?
Yeah, so the most commonly used antipsychotic by far here at our institution and in the study was quetiapine, followed by haloperidol as kind of an IV alternative. When we were designing the study, we really wanted to try to figure out a way for statistics purposes and to kind of relate all the antipsychotic requirements as a whole rather than looking at individual agents. So we actually came across the antipsychotic equivalence table that's published by the American Association of Psychiatric Pharmacists. And we decided to convert all of the antipsychotics that were used in this study to quetiapine, given this is our most commonly utilized agent here at University of Louisville Hospital. So a little bit less work for me on the back end for data collection.
And I think that's probably pretty standard. I think maybe the Mind USA, there's probably some ziprasidone users, but more or less, I'm guessing that's probably pretty representative of the general, critical care population as well. That makes sense. And you're exactly right. Anything that makes it a little easier for the researcher, we will accept with open and loving arms. So you mentioned transitions of care. Now, hey, we're trying to do our work in the ICU, but yes, you all in the internal medicine field are certainly the pros pro at this. And so I wanted to end with a question kind of related to that, right? So in this study, 30 to 35% of patients had their antipsychotics continued at discharge. And that's something I think we're pretty attuned of. There's been a lot of literature coming out, but 45% of them had melatonin continued. So why do you think the rates were so high here? And how do you think, us as pharmacists can kind of help in this scenario in a de-prescribing kind of fashion?
Yeah, so I think you make a really important point on antipsychotic de-prescribing. I think our study definitely highlights the importance of this concept. I did want to mention that given our patient population was a neuro-ICU patient population, several of these patients are discharging to acute inpatient rehab, subacute rehab, where there may still pose a risk for delirium and definitely poor sleep quality. So that may explain a little bit of the overall high rates of both antipsychotic and melatonin continuation at discharge. I think as far as principles for pharmacists to emphasize antipsychotic de-prescribing, I think it really starts with the question of, do we really even need the antipsychotic in the first place, right? So have we optimized our non-pharmacologic measures prior to utilizing and jumping to our pharmacologic antipsychotic options? Oftentimes, the answer is yes, especially in the ICU. But I think that we should just continue to reevaluate this on a daily basis and determine when discontinuation is appropriate, and especially if that patient begins to improve, they're being extubated, their care is being downgraded to the medicine floor. I definitely think that it's a constant reevaluation process of when we can look to discontinue those antipsychotics. And then definitely whenever they're about to head out the door at discharge, doing our part in reviewing those medications and making sure that we get those antipsychotics discontinued if it's appropriate.
Well, what an awesome study. Not only was it, I'm glad it got some love at the Neurocritical Care annual meeting, but I appreciate you taking the time to come on and highlight it for all the listeners coming and sharing some of your expertise. So Madeline, I appreciate it. Thanks so much.
Thank you for having me, Nick. I appreciate your time.
Now, our next special guest is Ifeoma Ofebuna. Now, Ifeoma is an emergency medicine clinical pharmacy specialist at Memorial Hermann Memorial City Hospital in Houston, Texas. Find her on Twitter at Ifeoma. And if you're curious, Ifeoma's got 4 A's, which I appreciate. Ifeoma, how are you doing today?
I'm good. I'm so happy to be a part of the podcast. Very, very excited. I can unashamedly admit that I definitely fangirled when I met you in person. So this is like full circle moment for me.
It made my day for the listeners, just so everyone is very clear of whose day was made. It was certainly me. High praise. The honor is mine. I'm so glad that we get to highlight your awesome research. So let's kind of get into it here. So pharmacists decrease the number of protocol discordant 4-factor PCC orders for oral anticoagulant associated intracranial hemorrhage in a community emergency department. So Ifeoma, take it away.
Of course. So this was a single center retrospective study that kind of encompassed from January 2016 to December 2022. Kind of as you mentioned in the title, we were looking at the number of protocol discordant 4-factor PCCs that were being ordered in patients presenting with an ICH likely due to an oral anticoagulant, and just looking at some of the other factors that may have contributed to whether the 4-factor PCC was appropriately ordered and dosed. So just briefly, in the last few years, our institution transitioned from weight-based dosing of 4-factor PCC to fixed dose, but we saw the same trend in both groups. So the presence of an emergency medicine pharmacist at the bedside really helped to curb inappropriate ordering of 4-factor PCC and improve time to administration. I mean, I guess to toot our own horn, it's no real big surprise that having emergency medicine pharmacists at the bedside is essentially saving lives. But it's always nice to be able to kind of get the numbers on a poster, in an abstract, and really look at how much of a difference are we truly making. On average, our presence there shaved like about 37 minutes compared to the group in which the emergency medicine pharmacist was absent. Again, I would call that a big win. Some of the biggest trends we saw was that the discordant orders primarily happened overnight when we're essentially relying on our skeleton crew, and thus it's pretty obvious that crew is very busy supporting the weight of the hospital. So it's no big surprise, but it's definitely just very telling, and hoping that that's going to help lead us towards hopefully more coverage in the future. Again, in both groups, we did see that the majority of patients presented were on apixaban at home.
Well, what an awesome study. I think one of the questions that I wanted to ask, because obviously when we're comparing the role of the pharmacist in this process, that would imply that there's some time where a pharmacist isn't there. So what, like in this center, what's the pharmacist coverage in the emergency department?
For sure. So currently we are a very small team. So there's 2 full-time emergency medicine pharmacists. So it's me and my partner. We alternate between 7 days on, 7 days off, and we're doing about 10 hours of coverage on our, when we're actually there. So we also have 2 PRN ED pharmacists, but again, there's a gap of coverage. So that's usually your overnight to early morning hours. So essentially, again, our day-to-day hours are like 9 a.m. to 7 p.m. So trying to hit the prime time, but again, big gaps.
Well, anybody kudos to you too, because anyone knows that when you have to start some sort of program like this, especially a clinical program, it can take some legwork getting it off the ground. So kudos to you both. Clearly some good things happening here. Now, how is the PCC prepared? Is it like when the pharmacist is there, are they mixing it at bedside, or are we cashing in our chips, calling the IV room and making it, and just having them make it in a more timely fashion?
For sure. No, it's a really good question. Currently we're working really closely with our IV room pharmacists and our central pharmacists to pretty much, when I'm there and when my partner's there, we're anticipating when it's going to be ordered. We're kind of already calling the central pharmacist to give them the heads up. Proactively putting in the order, trying to figure out the exact factor count to, type in the actual order. And then I will go and pick it up if I can. And just, again, expediting from medication ordering to medication administration and arrival at the bedside.
And then what's next on the plans? Like what are future, as you're kind of looking into the steps forward to do with this research? What are kind of things going in your partner's heads?
Ideally, at some point, I don't know if one of our business manager will like this, but I would like to see, I think that there's room for this to be done at the bedside to shave even more time, right? Optimize what we can do. We're seeing that we're doing a pretty good job with our current process, but there's still room for even better optimization. And of course, the obvious is that I want more. I want a bigger team so we can capture those gaps and we can just really operate at the best and the highest that we can provide for our patients.
Well, studies like this showing all the improvements that you're adding to the multidisciplinary care of those patients in the emergency department, that's certainly how it gets started. So Ifoma, thanks so much for coming on, highlighting this awesome research. Thank you so much for the kind words, and appreciate your expertise in talking about all this stuff.
Yeah, of course. I'm so happy to be here again. Full circle moment. I think I shed a tear just being here, feeling like the beginning of my stardom is really happening today. So I really do appreciate being here and how welcoming you have been.
Well, when you become famous and a star, don't forget about all of us lowly folks, okay? You promise?
Of course I promise. If that ever happens.
Now, joining us now, recurring guest, friend of the pod, Andy Webb. For those unfamiliar, neurocritical care clinical pharmacist at Massachusetts General Hospital and creator of NeuroWise, a website he created to share deep dives and thoughts on pharmacotherapy in neurocritical care. He is on Twitter at AJWPharm. Andy, how are you? Thanks for joining us today.
Not too bad. Thanks again for having me, Nick. It's a pleasure to be here.
So, not shocking with all the awesome research that you're doing, that at the Neurocritical Care Society annual meeting, you were presenting posters there. And I wanted to give you the platform to kind of highlight a discussion into, I guess you'd say, the eBoost sub-study. So I'm going to give you the floor to kind of let the listeners know what your research was and kind of what you ultimately found.
Yeah, definitely. And thanks again for having me on the podcast and being able to talk a little bit about this. So yeah, one of the posters I had the kind of privilege of being able to present at NCS was some of the work that our team has done, really building the framework and the workflow for the ELECTRO-BOOST or eBoost sub-study of Boost 3. And so some of the listeners of the podcast may be familiar with Boost 3 or Boost 2, its predecessor, which is basically the prospective multicenter randomized control trial looking at brain oxygenation in severe traumatic brain injury. And ELECTRO-BOOST essentially is an extension of that study, trying to see whether or not there are signals on the EEG, which, similar to brain oxygenation, could be used to either predict or treat or target to see how outcomes look in traumatic brain injury patients. And so eBoost has a couple of different aims. Obviously, one, looking at the EEG itself, if there's different signals on the EEG that are associated with outcomes in TBI patients. But one of the other aims of the study is trying to see how medication administration and medication use also impacts outcomes. And because, knowing exactly what meds, be that sedation, seizure medications, vasopressors, analgesics, may impact the EEG, it was critical for the design of the study for every patient enrolled to have an accurate record of which concomitant medications they were receiving during EEG monitoring. And so essentially the build up to this work was that when eBoost was first designed, the way that it was built was that research coordinators would be doing manual data collection for every single one of those medication administrations. So many of the listeners on the podcast may remember their own residency research projects doing hours of chart review. And this was that, again, times 10, where they were going to be chart reviewing every single drip rate change, every dose administration, every tiny minute detail for, over the course of the study, hundreds of patients, while, they were on EEG monitoring, which could be 5+ days. And so it's an enormous amount of work for these research coordinators to kind of get all of that data and collect it accurately. And so really the build up to this work was essentially a recognition of the skills of the pharmacist, both clinically as well as some of the work that we do with our residents and our projects and our own research, of being able to essentially extract medication administrations for both administrative and research purposes. And so I was invited onto the research team to help essentially build a network within the study of each of the sites of this study being able to have a workflow to extract medication data for enrolled patients. And so this concept is called electronic data capture. It's really nothing that out of the ordinary of pulling a report out of your electronic medical record. But the idea is that myself at my own site, as well as the pharmacists at each of the individual study sites, would develop a workflow where they would capture the medication administrations for enrolled patients electronically, pull that out of their EMR, send that to the research coordinators, and then the research coordinators have an already organized, comprehensive list of all the medication administrations that could then be uploaded to a secure trial database. And so essentially what we did is worked with all of these pharmacists, built these workflows, built the reports, built the teams within each site for those trials to kind of work seamlessly. And then what we did is essentially validated that that work was working correctly and was also accurate and saved time. And so we were able to basically pull some of the manual chart review that had already been done on previously enrolled patients and compared it to electronic data capture reports. And no surprises, the electronic data was actually higher fidelity and higher accuracy. And so the electronic data capture was able to actually find a number of errors of manual chart review, just mostly minor things like date transcription errors and time transcription errors, but a couple of things that would be quite relevant to us as pharmacists, like doses were doubled in mistakenly and other things that could substantially impact some of the minor points of the analysis that the electronic data capture data was able to essentially overcome. And so basically the conclusion was that building a network of pharmacist investigators at each of these trial sites was feasible and definitely improved the fidelity of the data that we were capturing for the trial. And also just showed that we can have this kind of collaborative nature where we're all using our strengths for the good of the trial. And in addition, now that we have this high fidelity, minute-to-minute, comprehensive list of medication administrations for all of these trial patients, we're going to have an enormous database of knowledge that we'll be able to look at, not just for the purposes of the primary question of the study, but additional post-hoc analyses down the road. So we're really excited about what the the implications of having all this data available is.
This is so great. And I want to point out to the listeners, like when you talk about the errors, like for example, the time was supposed to be 0900 and it was put in as like 12:09 a.m. as an 0009, right? So like something so minor, but obviously in the scheme of this study, it could be a big deal. And so it's not like, I want to point out that these aren't like egregious errors. These are things happening when you're reviewing thousands of charts and truly like going through, like you're trying to find a needle in a haystack. Sometimes it feels like, and God bless all of you on this study, because if you've done research and got into the nitty gritty, typically all you want to do is never do that again, and you're going to find any way to make it better. So I love that we have pharmacists leading the way to help this. Now, on the poster itself, which for the listeners, right, we'll put a PDF of this on the website so you all can look at what we're talking about. But the research question asks if it was feasible to add a clinical pharmacist to this clinical trial team. So was there pushback at all? Was there hesitancy? Or was it more that kind of statement, just because there's nothing in the literature describing our role in this kind of capacity?
Yeah, I think it's exactly the latter, where at the start, there was a recognition that being able to pull medication administration data was kind of right up our alley, where it's something that, we might do for medication use evaluations, research projects, administrative work. And as pharmacists, we kind of are the most fluent in what that data means. So what, the different MAR actions are, what the times are, how to interpret the actual data that's exported. And additionally, the good thing, especially within neurocritical care, is our network is pretty tight. And so I am lucky to have contacts at many of the sites already, and was easily able to connect with pharmacists kind of across the country at all the different sites, or make new connections, which is one of the best parts of this project, was being able to meet so many awesome colleagues at hospitals I hadn't met before. And so I think the feasibility aspect was A, kind of identifying the fact that we as pharmacists have the skills to do this. And then B, the other thing that was really the big amount of work that went into this was the feasibility of actually having the pharmacists build some of those reporting capabilities at their individual institutions. And so, what we found is, here at MGH, we're spoiled by having really great reporting infrastructure built into our Epic build and our kind of research infrastructure. But a couple of the sites, we did kind of have to walk the pharmacists through working with their informatics team, getting reports built, and making sure that this could actually happen. And so it was great to be able to talk to a pharmacist who really understood what we were asking and have them work with their individual sites to get the workflow working to make sure that the trial could kind of run as smoothly as possible.
So this kind of sounds like it's one of the ways of research in the future, in a sense. Like, is this way an avenue to continue increasing pharmacists' involvement in this meaningful research?
Yeah, no, I definitely think so. And I think it's basically, in two different ways, that's absolutely true. So one, I think that there's definitely a role for pharmacists in all prospective randomized trials, especially those, or obviously those that involve medications, right? And so if there is a trial that involves a med, there's definitely a pharmacist involved somewhere, whether that's in your clinical trials pharmacy itself. But I do think that some of the knowledge and skills of the clinical pharmacist at the bedside really should be included in those trials too. Be that being involved in making sure that the trial's data is being captured appropriately, or just ensuring that all of the kind of information that you might be interested about your trial patients is being kind of captured, recorded, and accounted for within the trial. And I think the second way this is really important, and I think this is something that I feel pretty strongly about, is that we have electronic medical records for a reason, not just for patient care and making sure that we're kind of all staying up to date in the best way possible, but additionally, the EMR keeps all that data somewhere. And so I always say, whenever you are interested in a research question that involves data that is documented in your EMR somewhere, it's worth your time to figure out how to get that without needing to do manual chart review, and kind of spending time digging through those charts and being able to recognize that making these sorts of workflows to extract medication administrations or really any form of distinctly documented data from your EMR is a way to substantially increase the efficiency of any of your research projects. So, for example, one of the pharmacists at one of the sites who went through the process of actually building the report, having it available for not just eBoost, actually mentioned to me that she's been able to use this report not just for eBoost, but several other projects that she has going on that can substantially save hours and hours and hours of manual chart review and data collection. That, just to your point, makes research more enjoyable, because there is truly nothing worse than just doing hours and hours of manual chart review for data that lives in some warehouse somewhere.
Yeah, it's perfect advice, because you're doing the legwork now to make life easier for research in this study and for future studies, right? Understanding the limitations, because not only are you talking about manual data collection, but the possibility of you missing something and having to go back, which is man, that's number one fear when you're doing manual. And this is a way to help prevent some of that. So, Andy, thanks for leading the way. I appreciate you coming on, highlighting this study from the Neurocritical Care annual meeting, and appreciate what you're doing for the research world, my friend.
Absolutely. Thanks again for having me.
And just another big shout out to the pharmacy section within the Neurocritical Care Society. Felt very welcomed. A great meeting if you've never been to. If you're involved in the care of these patients, they're not a sponsor, but it's a great group to get involved with networking wise. Friends, reach out. Let me know what you think at PharmacyToDose, PharmacyToDose at gmail.com. A reminder, the link in the episode description, as well as the reference post on pharmacytodose.com. It has the research posters there, so you can view and see the great pharmacist research in a visual format for those visual learners out there with us. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out READ for easy access to research personalized for you, Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. The Critical Care PRN optimizes drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, go to critprn.accp.com. Again, that is critprn.accp.com. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. Users and patients should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.